Hi, I'm David Borland. I'm the chair of the board of directors of the Alliance of Cure Cavernous Malformations. I'm here in part of the organization because my wife has CCM2. She had a bleed in surgeries 33 years ago, 17 years ago, and 3.5 years ago. I'm really excited that you're here today. I'm thankful that you're here. I'm also excited for you. This is an excellent time to learn about what we're all going through, get great information, and talk to literally the experts in the world on this disease and issue. So what we're going to do today is have Q&A for our guests, who I'll introduce you in just a second. We have some questions that you've sent in already that I have, so I will ask those interspersed with live questions. And we hope to answer everything that we can. Okay, with us we have Dr. Gary Steinberg. He's the medical director of the Stanford CCM Center of Excellence and chair of the Stanford Moyamoya Center. He's also the former chair of the Department of Neurosurgery for these institutions. Also with us is Dr. Kelly Flemming. She's the vice chair of our medical advisory board, is a neurologist at the Mayo Clinic in Rochester, Minnesota, and she serves as a medical director for the CCM Center of Excellence in this institution. Okay, so I'm going to pass the mic to you guys. Is this mic on? Yes. So let's start out with each of you talking about how did you first get interested in CCMs and why do you continue to have an interest in it?
I can start. First, let me say it's really wonderful to be here and to meet all of you and hear about your stories. I'm quite impressed by the courage that you all have displayed in your struggle to deal with this disease. And I consider all of you really courageous warriors. You really are inspiring to all of us. And that is in part how I got into this disease, was seeing the devastation that CCM can cause to patients and families. I realized that there was, although we can't cure it, we can treat the symptoms of the disease, and we can surgically remove some of these malformations, and that does have an impact. I don't think many of you heard my talk yesterday. I talked about operating on the deep ones in the brainstem, of which I've done about 279. That's one of the ways that I became very interested, was the challenge of being able to help people with the particularly difficult cavernous malformations. When I trained, I'm an old guy now, but when I trained back in the 80s, we didn't operate in the brainstem or the thalamus because we couldn't do it safely. But with advances in computer imaging, navigation, anesthesia, instrumentation, we found that we could access these deep critical lesions through safe corridors. And so that prompted me to try to develop new techniques surgically to be able to remove cavernous malformation deep areas or eloquent areas near speech, motor function. Over the last 30 years, it's been very gratifying to see that not all, but many of the patients that we treat go on to really, have enjoyable lives despite living with the disease.
Thank you. Again, thank you for sharing your stories. I enjoyed the poster session yesterday too, as well as learning about all of your journeys in this condition. I got interested in cavernous malformations when my mentor, Dr. Robert Brown at Mayo Clinic, handed me a project. This was in the 90s when not a lot was known about cavernous malformation and what the natural history is, what happens if you do nothing, what's the risk of bleeding. And so I got interested in cavernous malformations through this project. But then as I met patients and they would ask me questions, can I exercise? Can I take this medication? Can I be on aspirin? Can I take oral contraceptives? And I couldn't answer those questions in the 90s and early 2000s. It really motivated me to learn more because I wanted to give you guys the answers that you deserve and that need to be answered. Recently, we published a paper about female hormones and cavernous malformations. So we've looked, over the years, one of my interests has been in what medications are safe and not safe. And so we looked at an array of medications, blood thinners or medications with blood thinner properties. And then I got interested in estrogen and progesterone because I'd seen a number of patients that within a few weeks had hemorrhage after starting some type of female hormone. And so myself and the group from Essen, Germany collaborated together, and we had 722 female patients. And we looked at over time, of those patients, 137 of which were taking a female hormone versus the 585 not taking a female hormone, what was the risk of hemorrhage? And in the female hormone group, the risk was 7.4% per year over about a 3.5-year time period versus 5.1% per year in the no female hormone. Or did I switch that around? Yeah, no, 7.4 in the female hormone and 5.1 in the non-female hormone. So it was statistically significant, suggesting there was an increased risk. But it's very difficult to study because as you know, the way we do studies like this is we look in your clinical medical record and say, was that person on a female hormone? Or we ask you, and do you remember, and is that medical record right with all the medications you're on? And so there's still a lot of things we aren't sure about, but we are concerned that in particular estrogen may increase the risk of bleeding from cavernous malformations. Estrogen, the higher the dose, may make a difference in terms of that, but we don't know that yet, but that's what we're exploring in the next phase of our studies, looking at specific individual types of hormones and specific delivery. For instance, transdermal vaginal estrogen have lesser risk than oral. And so we're exploring more details about this in terms of who is at the highest risk. I'm more concerned if somebody's having an expanding cavernous malformation that's growing or bleeding than somebody that has a tiny little dot, those little black dots on the SWI and not having any symptoms. If the cavernous malformation, I think somebody's question was, if the cavernous malformation has been removed successfully and they have a sporadic form, can they be on estrogen? And sure, if your cavernous malformation is sporadic and it was completely removed, then it's essentially cured.
If you have a question, Holly and Linda will bring you a mic, so maybe you can raise your hand as you do this. So, Dr. Steinberg, how do you make a decision about whether to do surgery or whether to wait? Every case is different, but in general, they'd like to understand that process.
Yeah, that's a great question. So I don't operate on asymptomatic lesions. The caveat is if a lesion is growing and it's very large in a young patient, then I may recommend surgery. But in general, would not operate on asymptomatic lesions. I have some patients with familial form who have hundreds of tiny little lesions. The reason we see them is because there's a little leak of blood. So what we're seeing really is not the actual lesion, we're seeing blood products. So when patients become symptomatic, if they have a hemorrhage that causes a neurologic deficit, depending on where it is, then I would potentially recommend surgery. As I mentioned, with advances in our surgical techniques, there's really no area except the posterior limb of the internal capsule, a very deep structure where does not tolerate any manipulation. Besides that, there's almost no area that we can't remove them, but it's a balance between the risks of operating there and the benefits. So again, it depends on whether patients have had multiple hemorrhages. For instance, in my series of brainstem vascular malformations, 62% had multiple hemorrhages. That would push me more, those are symptomatic hemorrhages. That would push me more towards operating. I follow our patients annually with MR scans, no contrast, no radiation. And so we can see bleeds that may be asymptomatic, and that might play a role too if there's continued bleeding and we're worried about it. But those are the main indications. Seizures are an indication, especially if we suspect that the seizures are coming from that particular cavernous malformation. It's not always so easy to determine that. Age is a consideration, so I can say this because I'm old now, but my body doesn't respond to injury or surgery as well as it did when I was 20 or even 40 or even 60. So that's a factor. Medical comorbidities are a factor. But in general, patients who have severe symptoms, recurrent bleeds, I'm aggressive in recommending surgery because I think we can do very well and safely remove that malformation.
Thank you. Go ahead, Karen.
As a follow-up to Dr. Flemming, when my daughter was going through IVF, she developed a meningioma, and Dr. Wad suggested that she discontinue. Did you find any meningioma growth during your study?
Meningioma, did you say? Yeah, so meningioma is a type of benign brain tumor. We didn't specifically look at that, and I would say that, in terms of CCM3 is the type that is typically associated with meningiomas, as well as the radiation-induced cavernous malformations. And we didn't specifically look at the meningioma growth, but it has been looked at in other series of people with meningiomas themselves without cavernous malformations, and I believe that estrogen is contraindicated in those patients.
Dr. Steinberg, you mentioned size as a factor, large and small, and I'm really new to this, so what is large classified as? Like, what size would that be?
It's all relative, but 4 or 5 centimeters is large, 3 to 5 centimeters. I've seen some malformations that occupy a quarter of the brain. It's unusual, and this is something we don't understand. Cavernous malformations are not tumors; they're not neoplastic, but they can enlarge in size. We don't know the exact mechanism, but they leak blood, and then they clot, and then they develop new vessels, and that's how they grow in size. So that can be a problem, particularly in certain areas of the brain. So that might be an indication, particularly in young people.
Hello and good morning. Oh, sorry. I have 2 questions for you. One, they're both for future generations. And the first one, Dr. Steinberg, is for future generations. I had my CM implanted, not implanted, in the smack dab in the middle of my brainstem. So would you be able to get that out without causing any disabilities?
So let me answer that first. The brainstem is such a critical area that we find, and I presented this too, about a quarter of patients are immediately worse after surgery. And same is true in the thalamus. About 25 to 30% are worse as if they've had a bleed. But if you look at results 3 to 6 months later, 86% of patients are the same or better. So that's what patients and families need to understand when you're operating in these critical areas, brainstem or thalamus, basal ganglia. So there's a third chance that you would be set back, but over the next 3 to 6 months, likely that you would improve in our series. But every patient's different, so I wish I had a crystal ball for each patient.
My second question is, one of my many surgeries was a ovarian cyst that I thought was due to stress from my CM. Everybody told me that anyway. But listening to my mom explain it to Dr. Murtuck, we don't know. So do you guys have any idea?
The question is whether your ovarian cyst is related to CCM or stress from CCM. I'll let Kelly answer.
Yeah, there are a lot of things we don't know yet. So I think that was another question in the bigger group too, was Ehlers-Danlos related to cavernous malformation? And people certainly have different diseases besides cavernous malformation. Are they related? Are they not? And I think we're just at the beginning of kind of understanding some of that, because the more scans you do, then you find these, especially in familial form, you'll find kidney hemangiomas, and you'll find vertebral body, the bone hemangiomas, and you'll find other skin lesions and other things. And so for familial form, we know there are other things that can happen. For the sporadic form, we don't know as much, but we don't scan everywhere else because patients aren't having symptoms. Both the German group, Philip Damon, and ourselves have noticed that patients with cavernous malformations have a higher incidence of autoimmune and allergic diseases. We don't know exactly how that fits in with everything, but we have noticed that correlation. But I think a lot more needs to be explored in terms of things you're talking about. And I think this Angioma Alliance, or sorry, the Alliance to Cure registry is helpful for that. So do join that, and the more patients we have in that, we might find some of these correlations.
Yes. So one of the things that you had mentioned is that for some of the MRIs with the contrast is for annual MRIs, do you recommend getting contrast for those MRIs or not getting contrast with those MRIs?
I don't think contrast is necessary for the MRs. Sometimes cavernous malformations enhance on MR or CT. Often they don't. And there's some circumstantial, not hard evidence that multiple doses of contrast with MR can accumulate. So I try to avoid it if you don't need it. And there's no radiation, and that's the reason I do screening, annually.
Thank you.
It's important for the diagnostic scan because like hemorrhagic lesions can be due to a lot of different causes. So it's important for the diagnostic scan, but I agree, we tend to not do any GAD with follow-up because you can see a hemorrhage. If something's hemorrhage, you'll see it on the standard sequences without contrast.
Thank you.
Hi, I just have a few questions. So the first one is, if you have found any relation with sleep apnea. I may also have a sleep apnea. I don't know if that's something that may have triggered the first bleeding. And the second question is, so my first bleeding, I felt it because I had a headache. But then I have a following MRI 3 weeks later, and I had a different bleeding, but I never felt that one. So how come we may have a bleeding, but we don't feel it? Is that normal? How many times should each cavernoma should bleed?
Yeah.
Is there any
Yeah, good, very
research
good
on
question.
that?
Very good question. So in terms of the sleep apnea part, there's some basic science suggesting hypoxia might be a trigger to cavernous malformation formation. And so some people, and we collected that data with the CASH trial, is Dr. Wad was started to look at sleep apnea as to whether that might be a trigger. We don't know for sure yet, but it's something that's being looked at. As far as your second question, it's not uncommon that as you do multiple MRIs over time, you'll see that most of the lesions stay the same size if people haven't had new symptoms. Some will, maybe 10% will get bigger, some 10% will get smaller, but mostly they stay the same size. But about 12 to 15% of patients will have asymptomatic hemorrhage, where it looks like it's bled and it's bright on this, what's called T1 sequences, but they haven't had any new symptoms. And it depends if it's in the brainstem or the spinal cord. The spinal cord's as big as my finger. If you have a little bit of leakage in the spinal cord, it's going to cause big symptoms, whereas if it's in the parietal lobe or temporal lobe, you might have a little bit of bleeding and there's enough space that it doesn't cause symptoms.
I was just wondering, and I don't think it is yet, but the different symptoms that you are seeing with CCM patients, are they going to be studying the different genes? Like, does CCM1 have more chance to have this or that? And is that something that's being looked at?
That is a great question. And so there are small studies of CCM1 and small studies, like 18 patients described with CCM3, and we need more people to be genotyped to do these kind of studies. And I'll see lots of patients with the familial looking MRIs, but there's pros and cons to undergoing genetic testing. But until we have more people undergoing genetic testing, we don't know the exact spectrum of these diseases. So I think it's important to consider that genetic testing.
Hi. First, I would like to say thank you to all the scientists and researchers and doctors that are bringing more exposure to CCM. My last visit to the hospital, the neurologist who came in to see me was with a resident, and he said to the resident, as a side note, you need to read up on this more because some of these questions for CCM are going to be on the boards. So a little hint to the resident that she should study up on this. My question is actually to satisfy one of my siblings. Have there been any studies of CCM and vaccinations? Because while I was in the hospital the one time, and the sibling has not spoken to me since, he asked this question and I kind of knocked this down. He said, do you think that because you got the COVID vaccination that this bleed happened? And I said, considering the fact that I have a sister that was diagnosed 15 to 20 years ago and another sister that was diagnosed 30 to 35 years ago, I think it has nothing to do with it. And he hasn't spoken to me since. He was obviously very passionate about this, that this is what caused this. So regardless of the vaccination, have there been any studies of CCM and the effects of vaccinations?
I haven't seen anyone publish on that.
No, I haven't either. This is a hot topic, of course. I mean, you know, one of the Democratic presidential candidates is running, who's running is also passionate about, you know, anti-vaccination. But I don't think there's any evidence that any kind of vaccination can cause a malformation to form or can cause one to bleed. On the other hand, if you get sick from a disease that could have been prevented by vaccination, the illness could potentially, cause problems with your immune system, stress the system, and lead to factors, a hemorrhage. So in balance, in my opinion, especially if you have other diseases, including CCM, it's better to get vaccinated than to get COVID or some other disease. COVID has been associated with stroke, not CCM necessarily, but with certain types of stroke.
Can you talk a little bit about neuroplasticity after a bleed that causes deficits?
The question is, can neuroplasticity, can it help with deficits?
I guess just like what you've seen with neuroplasticity and the effects that it has over time.
Yeah, I mean, that's why we invoke neuroplasticity is the ability to recover after injury. So all of you know that infants have great plasticity in their body. So infants can suffer a stroke, be paralyzed on one side. Toddlers can have a stroke at a young age, can't speak, and they make complete recoveries. It's quite amazing, and that's because of this phenomena we call plasticity. That's the ability of the brain and other organs to be able to recover. We don't understand all the mechanisms in the brain. It's due in part to other areas of the brain that haven't been damaged taking over the function. It may be due to neurons sprouting new kinds of projections, developing new contacts. So we know that over time, the ability of the brain, particularly the plasticity, decreases. But that's why if you have a hemorrhage and you have a deficit, patients do recover to different degrees because of this plasticity. We're trying to promote plasticity, so besides my clinical practice, I have a research program. One of the things I've been investigating for about 30 years is using stem cell transplant to promote plasticity. We started this in 2000. I started transplanting human stem cells into rodent, rat, and mice stroke brains after the stroke, and remarkably we found that we could recover function, not completely but substantially. The initial notion was, of course, that the stem cells turn into neurons and other cells in the brain, and they reconstitute circuits, and that's why the animals were recovering. But we found out, and we were one of the first groups to find this, that's not the primary reason that the mice and rats recover. The reason is that these stem cells pump out very powerful growth factors, angiogenesis factors, molecules, and proteins that enhance native recovery or plasticity, to your point. We learned that, and so it took, it took me 20 years and $36 million in grants and philanthropy to get approval from the FDA to start a trial. And I was fortunate to get a $12 million grant from a California Regenerative Institute. And we started a trial in patients, actually a year and a half ago. Right now it's a single site. So we're treating adult patients who have had ischemic stroke. I don't think any of them have had, it's not hemorrhagic yet, because the ischemic stroke is much more common. Quite remarkably, we are seeing improvement in patients who are years out from having their stroke. They're not normal, but we're seeing, in some cases, very meaningful improvement. So the hope is that we will, continue to see recovery, do a larger multi-center trial with a control group, ultimately be able to get FDA approval for stem cell transplant, and that we would then generalize it to treating hemorrhagic patients like all of you who have deficits from stroke. But it takes a while, so we're talking about another 10 years to get to that point if we make it. But plasticity is key. We don't understand completely how it works. We invoke plasticity in terms of recovery.
Going back to something was talked about earlier when you were talking about the CCMs in different parts of your body. So our youngest daughter has gone through a full genome mapping right now because she does have the CCM. We haven't seen any symptoms from it, but she's had several other things and had heart surgery a couple of years ago. My question is, should we, the next time she's getting an MRI to check on it, should we actually recommend or ask about getting a full body scan versus just the brain?
So usually with the familial form, I usually at least recommend getting the spinal cord. I mean, a lot of people get the brain, but at least get the spinal cord, cervical and thoracic spine, so the up from there to there. In terms of the lesions, like in the ones that are in the vertebral bodies of the bone, or the ones that are in the kidneys or the livers, usually it's an incidental finding, meaning it's there but it doesn't cause symptoms. The same with the skin, and they can be in the retina as well. They don't usually cause symptoms. I think there was a couple published cases of the vertebral body, the bony ones, potentially being associated with fracture, but you would see those on the spine MRI when you did that. So I don't usually recommend a whole body scan.
I agree, but we do include the spine.
Hi there. I, again, want to thank you all so much. For Allison and me, it's especially wonderful to see Dr. Steinberg, who is Allison's doctor. Allison is an identical twin. Her twin also has CCM2 familial. Of the two of them, she's the only one who's had a surgery. But they both, within this last several months, which is 6 years out from our discovery of this whole thing, have had seizures. Does a seizure automatically mean that you have epilepsy? Allison got Elizabeth got great care. She lives in Portland, Oregon, after her seizure. Allison just recently had a seizure and got horrible care at a local DC, and she now has to figure out whether to go to Virginia or Pennsylvania, I guess, or back to Stanford for further care. But I'm curious about the seizure and what it means.
Yeah, I'll let Kelly answer, but in my opinion, a seizure doesn't mean you have epilepsy. Some people have a single seizure. In fact, when we operate on the brain, it's rare, but probably 5 to 10% of patients would have a post-operative seizure, which doesn't cause any permanent damage and doesn't predict future seizures either. So usually those patients we treat with an anti-epileptic medication, but we wean it off. I wean it off after a few months, actually. Epilepsy in general has to do with more, medically intractable seizures. But I'll let Kelly.
No, I agree. And just for those with the familial form, Helen Kim has published over 320 patients with familial form cavernous malformation, that about 60% of patients by the age of 60, I think it is, will have at least a single seizure. But that means 40% never have one. And she's published some data on hemorrhage risk in the familial form as well.
I think there's a lot of questions around seizures, and it's good that she asked in the order that she did, because the location of the cavernomas rather than the cavernoma itself is what's causing the seizure, essentially, correct?
Right. So cavernous malformations on the surface of the brain are at risk for causing seizures, but those in the brainstem or the thalamus or the spinal cord will never cause a seizure.
Well, it's interesting because the area, I have a DBA beside a cavernoma in the parietal temporal area, and I'm getting like tachycardia and things that are kind of partially indicative of what a seizure would be. But I know there's so many different kinds of seizures that are out there that I guess it's an ever-growing thing that you're constantly determining what this thing touches or what hemorrhage residue would touch to determine what the effects are. Is that correct?
Yes, I think, so sometimes people will have spells that are truly seizures, and then sometimes there'll be other things. I don't know if yours is on the right side of the brain, but there's a certain part of the, okay, there's a certain part of the, what's called the insular cortex, where sometimes people will have tachycardia. Okay. No, that's okay. There's a certain part of the right, it's called the insular cortex, where if people have a lesion there, sometimes they'll get tachycardic episodes that are not seizures. They're related to the expansion in that region. So it's always hard when people have spells. We have to look at what the symptoms are. We have to look at where the lesion is, what it looks like on the MRI scan, and see if we can decide if they belong. And most of the time it's easy, and then sometimes about 5 or 10% of the cases we can't agree on that between neuro and neurosurgery and the patients. But
I had the same thought when you mentioned the heart, the heart rate problems. There's a connection between the right insula. That the insula is the area between the frontal and the temporal lobes come close together like a book. And if you open the book, there's a surface deeper that's called the insula, and that has connections to the heart. Probably somehow through the vagus nerve. And so it can have sometimes profound effects on causing bradycardia or slowing the heart rate or other heart arrhythmias. So that may be what's, hard to know without seeing your scans and everything. But
to piggyback off of her question, I recently had the seizure in the parietal lobe, and I had that one removed, but the one I have in the brainstem, what is kind of like, what are the symptoms, what you see happen there?
Not seizures, but the brainstem is a very small area. It's a little bigger than the spinal cord, but in the medulla is not much bigger than the spinal cord. The pons, it expands a little. The midbrain is small. So in a very small space, you've got a large amount of high-priced real estate going through it. You've got all the nuclei, the cell bodies of the cranial nerves that supply your face, that move your eye movements, keep your eyes open, provide sensation to your face, move your face, move your tongue, control your speech. And then you've also got all the long tracts coming from your cortex, going down to your face, arm, and leg to control motor function. And you've got all the sensory tracts arising from your legs and arms and face going up to the cortex. All of that is compressed into a tiny area, so you can have multitude of symptoms related to any of those.
I'm thrilled to hear about your stem cell research, Dr. Steinberg. That sounds really promising and exciting. But my question is regarding the MRIs. Would it be your recommendation to, just as a general policy, symptomatic or otherwise, have annual MRIs to check on? And I'm of course speaking for myself, my daughter with CCM3 and multiples in her brain.
Yeah, I do it, and I think that's aggressive, and you might argue from a national point of view, it's not cost effective to be doing it, but for individual patients, particularly those who have had surgery, because there's a small recurrence rate, about 4% after resection. So I think it's important to make sure they're not coming back if they were causing problems. But even in those patients who we haven't operated on, it's important to know whether they're bleeding, even asymptomatically and enlarging in size. But I think if you canvass everybody who follows cavernous malformation patients, they don't do annual scan. What do you do, Kelly?
yeah, I think it's hard because that if the lesion hasn't caused symptoms, you're probably not going to take it out, so why keep looking at it? But I always, if it's a hemorrhagic lesion, I always do at least a 3-month follow-up if there's no surgery, because sometimes, again, a hemorrhagic lesion can mimic other things, and you want to make sure it is a cavernous malformation and not something else. So I always do one at 3 months and then at a year for somebody not undergoing surgery. And then if they've had surgery, we usually do one at 3 months and at a year again, just looking for the same thing, the remnant. And then I have a discussion with the patients about, okay, we could do this every 2 to 5 years. We could do it only when symptoms, look at how anxious they are, if they're familial or not, because if familial patients, we want to see if they're developing new lesions, whereas sporadic form, maybe we'd only look at it if it's symptomatic. And again, all the follow-ups don't need the gadolinium, but I kind of have that discussion with the patient and we decide together about the frequency.
Do you have a association with the scans or the MRIs for the upper body and scoliosis? We've had scoliosis, we've had the scoliosis surgery, and there were no lesions in the inner spine at the time. Is that something, though, to keep an eye on since she has a history of the scoliosis?
There were no lesions in the spinal cord?
In the spinal cord or in her spine.
So it's likely unrelated to the cavernous malformation and something different. So, I wouldn't see a need, to scan, regularly for the scoliosis.
So just focus on the brain during the MRIs.
Yeah, if exactly.
And not anything else.
If they've already excluded them in the spinal region.
Okay.
But I should mention, young children, I don't do routine scans annually, especially if they would need anesthesia or needing anesthesia, and also, I mean, young kids often won't tolerate it, and I don't think it's necessary, below the age of, teenagers, say.
So let's do one that you guys sent in earlier today, or in the past. Dr. Flemming, what are the things in kind of daily life that people should do, shouldn't do, maybe reduce risk?
Yeah, I think that's a good question, is people, when they've had a hemorrhage and their options are brain surgery or do nothing, it leaves a lot of anxiety because they want to have control over at least some part of this. And so there are some things that you can do. And I think one thing is there is some indirect evidence that vitamin D might be useful, and I think many of you probably know that already, but that there was several studies. Dr. Gibson actually was the first one, the Recursion pharmaceutical CEO was the first one to discover that vitamin D might also, besides Tempol, make those cells look better. And then there's 2 studies suggesting that patients with hemorrhage had lower vitamin D levels than patients without hemorrhage. So nobody's done the study, half of you get vitamin D, half of you don't, but it seems like a reasonably low risk with a possible benefit. And so I generally tell people to either, with their diet, or 1,000 to 2,000 international units a day is safe. If you start to do 5 and 1,000 or higher, you can get yourself into trouble unless you're deficient. But that seems like a safe and reasonable thing. The data on the gut microbiome and reducing emulsified foods seems like a reasonable thing. We all should eat more fruits and vegetables and less processed food. Seems like a reasonable thing. Helen Kim's data, even though we haven't seen a correlation between hypertension and cavernous malformation bleed, her familial data would suggest that systolic blood pressure less than 130, at least they saw a lower bleed risk. So again, it seems like a reasonable thing. In the estrogen data estrogen progesterone data that we looked at, is patients that were on those female hormones plus tobacco use increased the risk by 5-fold as compared to those that were not tobacco users. So again, seems like a reasonable thing to do. You can exercise, especially aerobic activity, and we encourage that. Light weight lifting is fine, high reps, low weights. there's not enough data to tell us if really heavy weightlifting is safe or not. And when I say heavy weightlifting, I usually tell people if it's so heavy that your face is turning red and you're holding your breath. Because what's heavy for me might not be heavy for you, so that's heavy to me. And so there are people that suggest don't do heavy weightlifting, even though I don't think there's really data to support or to refute that's okay. But exercise is fine. And one of our particular interests was looking at other medications that might have blood thinning effects, and we really haven't seen that. Paradoxically, you don't see that blood thinners or medications that have blood thinner activity increase the risk of hemorrhage, and there's several theories about that, but estrogen was the only one that really is the medication to avoid.
Thank you. Next question.
So as I mentioned before, I'm like still really early in all this information, and I'm trying to figure out what's the next step I should be taking to try to figure out if this is familial or if it was just sporadic. One of the things I read online was about getting in a semi-weighted MRI, but then a lot of people here have told me that they've done genetic testing. So what would be the next step?
It should be fairly straightforward on the MRI if the MRI has the appropriate sequences. So SWI, or susceptibility weighted image, and then there's something also called gradient echo imaging. It's just, to me, I don't know the physics of it, I'll admit, but it looks at little microscopic kind of little microbleeds. And so usually with the familial form, it's pretty obvious. You'll have multiple lesions on that type of imaging, and it's pretty obvious. Occasionally it's not. With the sporadic form, sometimes there's a little funny little vein next to the cavernous malformation, and that helps us to tell familial versus sporadic. But the MRI, if it's done with the appropriate sequences, you should be able to tell from there, and if it looks sporadic, you don't need genetic testing.
Okay. I have the sporadic form. I just want to know, is that CCM1?
Yeah, good question. So it's a little bit of a confusing nomenclature or how we think about it, but we think about sporadic, and then we think about genetic. And the genetic are CCM1, 2, and 3. There's 3 different genes that are all inherited in what's called an autosomal dominant fashion. But if you have the sporadic form, you don't have to worry about genetic testing. Your family, your siblings don't have to worry that they have it as well.
Okay, and then my other question was, when I was younger, I would fall a lot and I would bleed a lot, and it went to the point that it bled out of my eyes. So I always wondered, was that like leading towards the carcinoma in my brain, or no?
It's hard to say unless you had imaging. I don't know, the bleeding in the eyes would be a little bit unusual.
I was bleeding from my nose, and then it went to my eyes.
Yeah,
then I went to the emergency room, but
yeah,
they didn't do any imaging.
I haven't heard of that associated with cavernous malformations. There's other conditions that can be associated with that, but if you had numbness or you had other symptoms at some point in time but didn't get imaging, it's possible those symptoms were related, but we just don't know without having an MRI at the same time of the symptoms.
Okay, and my next question is for the Dr. Phillips? Steinberg, sorry. So 2 years ago, I had another hemorrhage, and I spoke to I'm from New York. I go to New York, Columbia, and my neurosurgeon is Dr. Colony. He referred me to see an epileptic doctor to do a micro laser ablation surgery where you heat it from the inside out. Have you ever done that surgery?
No, I haven't. It's a newer technique. It's putting in a little electrode and passing current through that generates heat. It's a common procedure now for epilepsy in general, but not necessarily for cavernous malformations. There are some ongoing studies which are looking at that, and it may be a good treatment. We don't know yet, if it's going to provide, you're not removing the cavernous malformation, you're burning it basically, and that may inactivate it. The one concern is that it might cause a hemorrhage at the time of the treatment. Sounds like you didn't have any problems with the treatment. So some people are exploring that. Another treatment surgically that's being explored, and I think there's a poster about it here, is using focused ultrasound, which is delivered through the skull. It's another form of energy. That's now has been approved for treatment of tremor, essential tremor, Parkinsonian tremor, and it's being used in brain tumors, and it's being tried for cavernous malformations also. So there are some other treatments, and I would include the laser interstitial as a potential treatment that's being explored. That's a good question.
Okay, so we're running out of time, and we've got two last questions for each of you. Dr. Steinberg, they didn't get to hear your presentation yesterday, but talk to us a little bit about that and things that are giving you hope for the future.
Yeah, so what I talked about was resection of cavernous malformation in the brainstem. I've done, I think, 279 of them in 250 patients. And then I've done another 50 or so in the thalamus and basal ganglia, another deep area in the brain. And as I mentioned, 30 years ago, we couldn't deal with those. We couldn't operate on those. We tried back in the late 80s and early 90s treating cavernous malformations with what's called radiosurgery. Have some of you heard of that? Gamma knife, cyber knife. We actually used cyclotron-generated helium ions and protons. And most people, including me, believe it does not work. And when you treat the malformations in the deep areas like the brainstem, the risks are very high of having problems with it. So we treated a number of patients, about 60. I had to operate on more than a dozen because they kept bleeding. And sometimes I had to treat the radiation injury. There is one group, University of Pittsburgh and some other groups around the world, which are still treating what they call unresectable vascular malformations with radiosurgery. And there's a little evidence that it doesn't change the bleed rate for a few years, but maybe it changes it later. But there's certainly not the same response of cavernous malformations to radiosurgery as with another disease known as AVM. An AVM, I noticed. AVMs are different biologically. Maybe that's why they respond differently. They respond very well to radiosurgery. So that is something I don't recommend. And now, what does give me hope is that we can resect these with, I think, acceptable morbidity in almost anywhere in the brain. So, the other things, I'm hopeful that we're going to develop medical treatments. What I found and presented yesterday, as I mentioned, was that we set patients back. About 26% are worse right after surgery, but as I mentioned, they recover within 3 to 6 months. So 86% of patients are what we consider good results, not necessarily normal. If patients with brainstem vascular malformations are in good shape neurologically before surgery, highly likely they will remain in good shape. Patients in poor condition, less likely, although sometimes we're surprised. We see patients who have very bad bleeds with neurologic morbidity, and after surgery, they make good recoveries also. But much better to be in good shape, and that's why I tend to be more aggressive if patients have had multiple hemorrhages, even in critical areas. Hopefully, we'll develop a medical treatment in the future. We were, participated in the recursion trial and, other trials. We'll see. That would be great if we don't have to operate. Maybe these other modalities, focused ultrasound, laser interstitial therapy, putting a probe in and freezing the malformation, maybe they'll turn out to be less invasive, than, opening the skull, but we'll see.
Same question.
Yeah. Well, I was very excited about the meeting yesterday and learning so many new things. The gene therapy that may be available, or that the trials are at least starting in animal models, as well as the new methods to get medications to clinical trials faster. Because as Dr. Gibson mentioned, sometimes it takes 10 to 15 years to get a clinical trial from the start of the medication to the initial animal studies, and then you have the phase 1 and the phase 2 and the phase 3 studies. Is now, between what I learned yesterday and today, it seems like there is enough technology that we're going to move those medications faster and into clinical trials and hopefully get answers, because I think there still are patients where surgery is still difficult, and or if you have the familial form, how many surgeries can you tolerate before other things happen. So I'm very excited about all the new medical therapies coming down the pipeline.
Great. Well, thank you very much for all the answers and all the information that you've had today.